Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I'm your host, Dr. Kishore Volodi, and today we have a listener question, always my favorite podcast to do, where we have you, the listener, decide what it is that we're going to be talking about on the podcast. And today's question, boy, it's a tough one. It's one that doesn't have a lot of clear data for it, and really becomes more of an idea of what are the experts doing these days. And well, it has more of an adult feel today. We're going to be talking about cholesterol management in Down syndrome, though we'll see that there is a pediatric component to this as well. But before we get into this whole topic, I want to introduce our speaker. Actually, Brian, I'd like you to introduce yourself, if you could, Dr. Chicoine. Let us know who you are, what you do, and why you love doing it.
Great, sure. Thank you very much. I'm Brian Chicoine. I'm the medical director of the Advocate Medical Group Adult Down Syndrome Center in Park Ridge, Illinois, a Chicago suburb. We've been taking care of adolescents and adults since 1992. And people ask me why I do it, and I say, come meet a few folks with Down syndrome, and you will have no question why I do this. So they answer the question for us.
Yes, yes. Dr. Chicoine was definitely one of the pioneers in this idea of clinics specifically for people with Down syndrome. And so he's had a lot of experience, and I'm sure a lot of experience in this question we're going to have today, which is on cholesterol management. So, in general, when we think about cholesterol management, we're thinking about in pediatrics, they recommend that we check a cholesterol level once somewhere between the ages of 9 and 11. And again, as they reach adulthood between 17 and into 21 years of age. And then in adults, and correct me if I'm wrong, Brian, but every 4 to 6 years, unless you have a risk factor, and then it's every 1 or 2 years if you do. But we don't know if those guidelines really are applicable to people with Down syndrome. So, what do we know about cholesterol and specifically cholesterol issues in Down syndrome?
Well, maybe I can start with, what did we put in the global adult healthcare
Sure.
guidelines?
Yeah.
So the recommendation there was we start at age 40 and check a cholesterol every 5 years, and then consider appropriate therapy based on that. And the recommendation was to use there's a calculation, there's apps for this calculation for determining someone's 10-year risk of having a cardiac event. And then based on that, you plug and chug the numbers into that, and then you come up with a percentage, and below a certain number, it is thought that continue with the diet and exercise recommendations, and above that, consider adding a statin.
And when we think about that, that's specifically, of course, for adults with Down syndrome, as you were sharing in the adult healthcare guidelines, and we'll put a link to that in the show notes for our listeners. But there's a bit of controversy when it comes to cholesterol and Down syndrome in terms of, one of the things that we often think about for cholesterol issues in the general population is plaques in the arteries around the heart and leading to heart attacks and things like that. Um, but can you give us a little bit of an idea of of why maybe in Down syndrome we may not have the same level of concerns?
So, yeah, it's a very fascinating topic. Some people have in the past have called Down syndrome an atheroma-free model, which
Mm.
means they don't tend to get these plaques that the rest of us tend to get, that end up causing, a leading cause of heart attacks or myocardial infarctions, as well as a leading cause of strokes. So people with Down syndrome just don't seem to get that very often.
Mm.
And so there is apparently something we don't know yet on the 21st chromosome potentially, or something on the a change in the something that's generated by the 21st chromosome that affects a different chromosome. We don't really know how that occurs, but there is something that seems to protect people with Down syndrome against that disease. I joke that whatever it is, I'd like some in a bottle. I have a significant family history of atherosclerosis and myocardial infarction, so I'd love to have some, but we don't know what that is yet.
It's so fascinating. I mean, and it's one of many things that we've thought about over the years in Down syndrome in terms of something protective on that 21st chromosome. We've talked about probably even on this podcast about, a lower incidence of solid organ tumors and then you add something like this to it and lower incidence of high blood pressure and all these things that a general internist or family practice doc is going to be seeing in all of their adult patients, yet we don't see them as frequently in Down syndrome, which is just fascinating. So I guess a question that would come up then is if we think that they don't really have very much risk to cholesterol levels, at least along the heart, why should we be checking those levels?
So when we can go back to the guidelines for a second. When we were
Yeah.
looking at the guidelines, the sense was there wasn't enough data to tell us for sure not to do it.
Okay.
So we went ahead and made the recommendation to do it as was. And I can tell you my own experience, based on following those guidelines. I have not had a single patient that I ended up starting on a statin
Hmm.
because of those numbers, because the risk for cardiac event comes out low enough that it doesn't meet the criteria to start someone. Um, so that's just been my experience so far.
Yeah, so because of the fact that your patients have Down syndrome, you're saying when you plug in all the risk factors, depending on what the number comes out, you have not had to start a cholesterol lowering medicine for your adult patients. Is that what you're saying?
Correct.
Oh wow, okay. And and then there's some concern or data that talks about cholesterol levels in Alzheimer disease. Now that I think is in the general population, but correct me if I'm wrong. But do we have, of course, we know that Alzheimer is more common in people with Down syndrome. Is that a reason that we might want to keep their cholesterol levels lower?
Yeah, I think that's a great question. So there's some studies in the non-Down syndrome population that looked at people with higher cholesterol seem to have a higher risk of Alzheimer's disease. Now, you can't make the leap that the high cholesterol causes the Alzheimer's disease. Those studies haven't been done. So you'd really have to do a study where you took a population of people with high cholesterol and put some on statins and didn't put the others on statins, and then followed them over time and found that the people that were on the statins had lower incidence of Alzheimer's disease. That study has not been done yet.
Hmm.
And so we don't know for sure that lowering the cholesterol in somebody does in fact reduce their chance of having Alzheimer's disease. And again, that's in the non-Down syndrome population. So out of that is there's sort of a phrase, and it's not medical, it's not a medically accepted thing, but it's just sort of a general phrase. What's good for the heart is good for the brain, and,
Hmm.
and in some ways we know that's true. So if you have atherosclerosis or hardening of the arteries in the heart, and you have it in the arteries going to the brain, and you have strokes, that's clearly not good for the brain. Um,
Yeah.
but on the other hand, is that true in people with Down syndrome? So the thing that's really sort of a real disconnect for me is that we have so little atherosclerosis in the heart and actually in the neck vein, the veins going into the brain as well. But we have this huge lifetime prevalence of Alzheimer's disease in people with Down syndrome. So, if in fact there was a one-to-one correlation between heart disease and Alzheimer's disease, it doesn't fit in people with Down syndrome because there's very
Yeah.
little heart disease, atherosclerotic heart disease, and a very high rate of Alzheimer's disease. So there's clearly other factors involved here that we don't understand at this point.
Yeah, and it just highlights the need for research.
Absolutely.
We know that at least pediatric level research in Down syndrome, while not great, has always been a little bit ahead on the than the adult side. And I think a lot of that comes from there just aren't a lot of adult practitioners who do what you do, Brian, where there's an interest in working in this population, specifically doing research in this population. And I think one of the things that you all uncovered as you were writing the adult healthcare guidelines was just really how little data there is to drive a lot of our decisions. Do you get a sense that as time passes, that might change, and maybe our recommendations for cholesterol checking in people with Down syndrome might change over time too?
Yeah, I think time will tell. I think one of the things, if life expectancy certainly plays into that as well.
Hmm.
And so, I say when I graduated from medical school in 1984, the life expectancy of people with Down syndrome was about 28, and now it's about 60.
Hmm.
So, I mean, if we were following that same trajectory, very soon it would be 70 and 80. But unfortunately, it has leveled off.
Hmm.
And Alzheimer's disease does seem to be the big factor in that life expectancy sort of being stuck at 60 for people with Down syndrome. So solid tumor, we talked about solid tumors, we talked
Yeah.
about atherosclerosis. If we, not if, when we address Alzheimer's disease in a very positive way, going forward, and particularly in people with Down syndrome, I would suspect that then we would see that life expectancy go up and up. And then all we learned about solid tumors and atherosclerosis, we need to go back and look at again, because now if
Sure.
people are living to be 80 like everyone else, will we start to see those conditions be more prominent?
Yeah.
I don't know that they will or won't, but we
Yeah.
definitely have to keep an eye on that.
Yeah, for sure, for sure. And so I would assume then at this point, we continue to follow the guidelines that were put forward in the global adult healthcare guidelines with checking the cholesterol every 5 years, as you had mentioned. And let me give you a hypothetical. So you check a cholesterol in somebody, their cholesterol, total cholesterol is 250. I think, normal we would desire to be what, under 200, under 180 for an adult, somewhere around
Correct.
there?
Correct.
Okay.
Yeah.
And let's say that bad cholesterol, or LDL, as we call it, was on the higher side, and the good cholesterol, the HDL, is on the lower side. So if you see that in a patient with Down syndrome, what are you going to start with for them in terms of how to help manage that?
Yeah, we'll certainly have a conversation, and I'll explain the guidelines, and I'll explain how this would be treated in somebody without Down syndrome, and then why we might not treat someone with Down syndrome in the same way, and then have a discussion with the individual with Down syndrome and their family, and then come to a decision. So in that situation again, um, we don't see a lot of atherosclerosis. See, I mean, it's an N of one. I mean, it's one individual. But several years ago, I had a patient who had a cholesterol of 350 for years,
Hmm.
and I talked to the family and to the patient and back and forth, and they decided not to treat the cholesterol. And then several years later, they goes, "Did we do the right thing?" And I said, "Well, maybe if nothing else, we can do a calcium score,
Uh-huh.
which is a calcium. It's a CT scan of the heart, and it it's not perfect, but it gives you some sense of if you have blockages, and a very high score is not good, and a low score is good, and his score was zero,
Hmm.
which is you can't get better.
Yeah.
So despite having this cholesterol 350 for decades, he had no evidence of atherosclerosis at all. Now, I'm not going to base my entire approach to cholesterol based on one individual, but it's a very fascinating thing. I think the other conversation I have with people is, we talk a lot about the side effects of
Hmm.
cholesterol medication, statins, and one of the side effects is muscle pain.
Hmm.
And for a lot of people, that'll if they've been on it a while, it'll go away, or if they switch to statin, it'll go away, and they won't have it anymore. I think one of the challenges with people with Down syndrome, there's some sense that they may be more at risk for those because of hypotonia, because of thyroid issues and other things. They may actually be more susceptible to the pain, the muscle pain related to statins. And the other thing is, pain in general is a challenging thing in folks with Down syndrome. For years, it was thought that people with Down syndrome had a very high pain tolerance because they didn't complain of pain. But as people studied that more, it became clear that they have pain, just they're maybe not reporting it, or they're perceiving it a little differently, or they're having a little harder time localizing it, or they have a delayed response to the pain. So clearly, people with Down syndrome have pain. In fact, some studies suggest people with Down syndrome have more pain than other people. So, so I think that's a tricky thing in it. And so if we're going to put someone on a medication that is causing them daily muscle pain and they're not
Yeah.
able to tell us, I don't think that's a great service to do them. And then the other side effect is concerning is memory impairment, which is seen in with statins. And now there is some, going back and forth, how much of a problem is this? But again, all these studies were done in the non-Down syndrome population. Will these
Right.
affect the brain of a person with Down syndrome differently? So there's some sense there's sort of two categories of statins. One is lipophilic, means it attaches more to the fats, and the other is hydrophilic, which means it's more soluble in water. And those that are hydrophilic probably cross the blood-brain barrier, into the brain less. So theoretically, if you took a hydrophilic one like rosuvastatin or pravastatin, you may have less memory problems. But then the question is, if it's getting into the brain less, will it actually have the impact potentially on Alzheimer's disease that we would hope that it has? And we just don't know the answer to that question. So I think it's tricky. I mean, I think we've seen over the years that people with Down syndrome probably are more sensitive to medication side effects, and
Yeah.
certainly medication side effects that affect the nervous system. So I would have concerns that we may cause more memory impairment than we prevent,
Yeah.
with the statins potentially.
Yeah, that's really interesting. I hadn't thought about that memory aspect of the side effects of the statins. And then, of course, as you so nicely kind of outline that if there is pain and yet they're not able to necessarily communicate that pain to their caregiver, there can be this kind of assumption of, oh, they're getting older or they're just getting lazier, and it may have nothing to do with that at all. It's probably achy pains that they just aren't able to necessarily communicate as effectively. Yeah.
Yeah, I mean, I mean, we look at this all day long, every day,
Yeah.
trying to figure out someone has a behavioral change, and
Yeah.
it's pretty easy to put your psych hat on and just attribute it to behavior
Hmm.
without thinking about pain. I think we, don't do them a service if we're not really trying to look at that potential
Yeah.
implication.
Wow. So yet another topic in our field that boy we could use a lot more data and research in terms of cholesterol and the treatment of cholesterol and things like that. I think pretty easy to say it's a good idea to always encourage a healthy diet, a healthy exercise, and things like that. But beyond that, I think boy the level of cholesterol that we should be treating or worried about or things like that in adults or children really with Down syndrome. I think it's murky. It still feels a little murky.
Yeah, so I think we have to be careful. We don't, without clear benefit, I think,
Hmm.
and the potential for side effects. I think we want
Yeah.
to be careful to be putting people on that. In fact, there are some, go back. I talked about the studies that associate in the non-Down syndrome population associate high cholesterol with Alzheimer's. There's even some studies that associate very low cholesterol with Alzheimer's disease.
Hmm.
So,
Oh gosh.
so if we reduce cholesterol, would it actually make the situation worse instead? But I just think we just don't have enough data.
Yeah.
So I think, like you said, I mean, there are so many reasons to exercise and to try to eat a healthier diet that
Uh-huh.
may or may not have anything to do with heart disease or
Right.
Alzheimer's disease. So, I would certainly encourage that anyway. And I think for now, I think that's the best advice that we have based on
Yeah.
the
Yeah.
data we know.
Awesome. Well, Brian, thank you so much for joining me on the podcast and answering this listener's question. Is there anything that, other than the healthcare guidelines for adults that I'll put in the show notes, is there any other resources or anything? I know you have a huge resource library there at your adult center. Is there anything particular to this topic that you would suggest that we link to?
I mean, we have a lot of information on our website.
Okay.
I would encourage for your healthcare professional. The
Yeah.
National Down Syndrome Society is coming out in a couple weeks with a program called Care DS,
Hmm.
which is educational, both a course and some reference materials that are really designed for the primary care health professionals. So, feel free to reach out as some. I was talking to a family, it's the reality is it's unfortunate, but families and people with Down syndrome still need to be sharing materials with their health professionals, because that's the way health professionals will get the material a lot of times. And so I'm sorry that still has to be the case, but it is you guys, the families and people
Yeah.
with Down syndrome have been a great resource for health professionals. So please feel free to share that information with your health professional.
Great. Well, thank you so much again for joining me on the podcast. And to our listeners, I hope you are generating questions that we can answer on the podcast. We've been doing this for so long now. I think we're well over 200 podcasts, as you can see. And so your topics are what drive this moving forward. So reach out to me at Down Syndrome Center at chp.edu if you have any questions you'd like us to answer. And if you would like to join us on the work that we do here at the center, go to givetochildrens.org/Down Syndrome Center. But until next time, bye bye.